Hello, everyone. Welcome to the CanVector National Thrombosis Seminar. These are the monthly seminars that are hosted live throughout the academic year, and they feature the state-of-the-art thrombosis, venous thromboembolism lectures presented by both Canadian and international experts. I want to alert you that the video recordings for these seminars are available on our website, and these seminars are self-approved group learning activities as defined by the Maintenance Certification Program of the Royal College. I would like also to thank the members of the Planning Committee chaired by Dr. Wong, and I'm Dr. Maha Othman, and I have the pleasure to moderate the seminar today. So it is my absolute pleasure to welcome our two speakers for today, speaking on whether, when, and how to restart anticoagulation after bleeding. Our first speaker is Dr. Deborah Segal. Dr. Segal is an associate professor of medicine at the University of Ottawa, an associate scientist at the Ottawa Hospital Research Institute. She holds a Tier 2 Canada Research Chair in Anticoagulant Treatment of Cardiovascular Disease. She received MSc degree in pharmacology and in health research methodology. She has published over 120 peer-reviewed articles, including high-impact journals such as the New England Journal of Medicine, Circulation, Annals of Internal Medicine, Canadian Medical Association Journal, Blood, and Journal of Thrombosis and Hemostasis. Our second speaker is Dr. Ashkan Shomanash, and Dr. Shomanash is an associate professor of medicine at McMaster University, where he holds the Martha and Owen Boris Chair in Stroke Research and Care, and the founder-director of the Hemorrhagic Stroke Research Program, and a scientist at the Affiliated Population Health Research Institute. He is a stroke neurologist who obtained his MD from McMaster University in 2007, prior to pursuing neurology residency training at the University of British Columbia in 2012. This was followed by fellowship training at Boston University School of Medicine and Massachusetts General Hospital, Harvard Medical School in 2014. So now I would like to alert you to the objectives of the seminar. And after the seminar, participants are expected to counsel patients on the risk of serious anticoagulants-related bleeding. They are expected to be able to apply best practices to restarting anticoagulation after GI and intracranial bleeds, and also apply principles of shared decision-making with patients, caregiver, and other health providers to optimize management for individual patients. I would like also to alert you that there is a chat function where you can submit your question anytime throughout the seminar, and we encourage you to do so. You can also raise your hand at the end of the presentation. We would like actually to try something different today and give an opportunity to people for some interactive discussion at the end. So now I would like to hand over to Dr. Segal, our first speaker.
Thank you so much, Dr. Othman. I'm also very happy to be called by my first name for a Q&A and stuff. So, it is really, truly a pleasure to be presenting today with Dr. Shomanash Ashkan, who I've known for many years. We used to work together at Mac, so it's great to be here with him. He's an expert in intracranial hemorrhage and in this space. And so I'm going to be talking about restarting anticoagulation after GI bleeding. Many of you will know that this is an area that I think a lot about, and I always put this photograph of the Don Wall, which was supposed to be an unclimbable rock face, which was climbed by a wonderful climber. It's an amazing documentary and very inspiring, because I think that this sometimes seems like such an impossible thing to study, but hopefully we will make some progress just like he did. Sorry, I'm just trying to. So I've received honoraria for educational presentations, paid indirectly to my research institute from some manufacturers of anticoagulant medications. And we've already talked about the objectives, and my objectives really are the same as though they're just focused on gastrointestinal bleeds. So I wanted to set the stage for the discussion, and some of you have heard me speak before, but really bleeding complications, we know limit anticoagulant use. And in 2023, we're lucky to have direct oral anticoagulants now available in a generic form, reducing the cost for patients. Many benefits of DOACs versus warfarin. Many people are familiar with this. Of course, there is a reduced risk of intracranial bleeding, major bleeding, and fatal bleeding compared to warfarin. So huge benefits for patients clinically. There is a signal that there is an increased risk of GI or gastrointestinal bleeding with DOACs compared to warfarin. And there are possible differences between DOACs, but they've not been compared head-to-head in randomized trials, although those are coming with the COBRA studies in VTE and AFib. Regardless, it's important for us as clinicians to understand that patients can experience bleeding complications, and 2 to 4% of patients still, in 2023, experience major bleeding events per year, and another 10 to 12% of patients experience what we call clinically relevant non-major bleeds. So still have to seek medical attention in the emergency department or at their family physician. And these rates, of course, vary according to the indication for anticoagulation. Nonetheless, we see these in both randomized trials and observational data. And what's important to remember is that we all can appreciate that anticoagulant-related bleeding increases the risk of death. To speak to the risks and conundrums that are faced by patients who experience hemorrhagic stroke, which Dr. Shomanesh will go into later on, patients who experience anticoagulant-related hemorrhagic stroke have an almost 30-fold increased risk of death. Another, with subdural bleeding, it's lower, but still 7-fold increase in the risk of death. And I think where I end up focusing my attention is on extracranial bleeding. Of course, the most common single site of extracranial bleeding on anticoagulants is from the gastrointestinal tract. And extracranial bleeding, which is surprising to some, increases the risk of death by 5-fold. So it is not benign. These patients still have outcomes, and there is a need to improve those outcomes. We know from these are the phase 3 randomized clinical trials that compared DOACs versus warfarin for atrial fibrillation. And this is really, this is not a meta-analysis, just these sort of absolute rates that of anticoagulant-related, of death after anticoagulant-related major bleeding in these trials. And you can appreciate in the dark blue boxes, the mortality rates with warfarin, ranging between 11 to 14%. Different patient populations, again, it's not a head-to-head comparison here. And also with DOACs, rates of 7 to 10%. So again, this is bleeding is a highly morbid condition. Patients can have short and long-term adverse events, and there really is a need for us to improve outcomes. In this Aristotle sub-study, that was the clinical trial which randomized patients with atrial fibrillation to apixaban or warfarin. You can see that 30-day mortality after anticoagulant-related bleeding was 43% in patients who had intracranial hemorrhage, and in those who had non-intracranial hemorrhage was 9%. So that means if you have a patient who you're starting on anticoagulants and they say, listen, doc, what's the chance that I'm going to have a major bleed? And you say, well, the risk is about 2 to 4% per year. What's the chance that what will happen to me after that? And you know what? The reality is we know that up to 10% of people after non-intracranial bleeds die after their bleeds. Now, they may not all bleed to death, but certainly this sets into motion a series of events that ultimately result in their death. Really important to remember, and I think sometimes surprising to folks, particularly when we focus on intracranial bleeding as the most feared complication of anticoagulation. We know that other types of bleeds can be very catastrophic. There are other consequences of bleeding, and this really gets into what we're going to talk about today, impaired quality of life, for both GI and intracranial bleeds, impaired functional status, and maybe Dr. Shomanesh will talk a little bit about that. We know that anticoagulants are held from patients who are eligible for treatment because of concerns about bleeding. And we also know that anticoagulants are permanently discontinued after bleeding for all bleed types, not just intracranial bleeds, but GI bleeding as well. And then finally, we know that DOACs are very frequently prescribed in off-label low doses with limited data to support that. And again, bleeding is a common problem. With the increase in the eligibility for anticoagulants with expanding indications, we realize now that bleeding is a growing health problem. And I wanted to also mention, just to sort of set the stage here, is that even in the era of DOACs, where we have specific reversal agents and other types of hemostatic therapies available, we see that patients have high rates of mortality, despite the fact that they have what we call effective hemostasis, or they stop bleeding in these clinical studies. So you can see on the right hand of this screen, this is a systematic review and meta-analysis of treatments for for DOAC-related major bleeding. You can see that of all the treatments, including four-factor PCC, idarucizumab, and andexanet, about 80% of people have effective hemostasis, which is great. But look at the rates of death, almost 20% in those arms. There is an important risk of thromboembolism as well, which maybe we can talk about. Of course, these complications play into our management and restarting anticoagulants, and so this is quite relevant to this discussion. So this is again, from when a patient has an anticoagulant-related bleed, it's just really important to keep calm and carry on and have an approach. Which means that, of course, there's a framework, and those who know me know that I'm a framework kind of gal. So I like to think about bleed management with all of the steps. And the step, of course, that we're going to talk about today is reassessing anticoagulants after bleeding, which is really part of bleed management. So what do we do after a patient has an anticoagulant-related bleed? There really is an unmet clinical need for evidence-based strategies. And I'd like to say in the gastrointestinal bleed space, we're not as far along as they are in the intracranial space, but we know that anticoagulants are permanently discontinued in up to half of patients after GI bleeds. And what's interesting is that if you talk to people about this out in clinical practice, they think that they start everybody back on their anticoagulants. But all of the data that we have suggests that a substantial proportion of people remain off of anticoagulants long-term, even after GI bleeding. What clinicians don't know, and what we don't have evidence to tell us, is whether, when, and how to restart anticoagulants. The data that we have, again, are observational, and much of it is derived from warfarin-treated patients. So, the optimal timing is not been established and varies widely in clinical practice. And I think because when we're considering the data that are available, it's helpful to just reflect a bit on the methodological challenges. Caveat emptor, it means buyer beware. So there are important considerations when we're interpreting observational data in this area. And this really does speak to the need for high quality randomized trials, although very challenging to do. Dr. Shomanesh is doing one, and perhaps he can reflect on his experiences. But we know that retrospective data collection means that there's a lot of uncertainty, including the ascertainment of drug exposure and when people actually restarted their anticoagulants. We know that drug exposure is also time varying, so that means that people can start and stop anticoagulants. If you're not following them prospectively, you may not capture this, and you may attribute drug exposure, which is erroneous. It can be challenging to determine the start of follow-up time. So is that after hospitalization, when the patient picks up their medications? And what's really important about this is to avoid something called, or be aware of something called, immortal time bias, which really is a type of bias that biases towards the favors the treatment. So ultimately, bit too much to get into, at this point in time, but happy to chat with people about that as well. There are methods to reduce the impact of immortal time bias. And then finally, considering the competing risk of death, which is very important in these types of studies, particularly if there's a high mortality rate, which I've just told you there is. That's helpful, important to keep in mind. But other outcomes too can be competing risks. So really anything that changes the probability of an outcome of interest is considered a competing risk. So in one of our studies, we considered the competing risks of death, thrombosis, and bleeding, because of course, if a patient on an anticoagulant has a bleeding complication, then that changes the probability of a future thrombotic event and death. So some of these things are important to keep in mind. Not all of them have been addressed in previous studies. I'm showing you this slide, which is a large cohort study that we conducted using Ontario data, which showed that patients, again, this is adults who were hospitalized for bleeding complications, who had received an anticoagulant or had been dispensed an anticoagulant in the prior 3 months. And you can see, if we just look at the top line, which is all bleeds, you can see that patients who resumed anticoagulation had a higher rate of bleeding and a reduced rate of thrombosis compared to those who did not. What's important to keep in mind here, although there is a mortality signal here, what you want to remember is that these are patients who are managed out in routine clinical practice by their treating physicians. And it is likely that patients who resumed anticoagulants had overall a better prognosis than those who did not. And so we take particularly, all of this is important because there is confounding at baseline, although we did adjusted analyses, et cetera. There are things that we can't account for. And particularly with the mortality outcome here, I would be very cautious in interpreting that. You can see here that in our study, 30% of patients remained off of anticoagulants at 15 months after their bleed. But it is important, and I think this speaks to the fact that we've separated this talk into two different bleed types, that not all bleeds are the same. And so there really isn't a one-size-fits-all approach, although I think we can generalize some principles of management to different bleed types. So I'm going to speak about gastrointestinal bleeding, which people may be familiar is quite heterogeneous. We have so many, and then this isn't an exhaustive list. This is just some that I could come up with, as a GI adjacent hematologist. I like to say that, you have peptic ulcers, and even peptic ulcers vary in severity. For example, there's very low bleed risk lesions, there's very high bleed risk lesions. You have GAVE, which often recurs, AVM, angiodysplasia, varices. I mean, all of these really are their own distinct etiology or pathophysiology and have their own distinct rebleeding risk. So in a little bit in this space, we're lumping together a whole bunch of pathologies into one, with the expectation that we would come out with a one-size-fits-all approach. And I would argue that that still is not possible even for GI bleeds. So this is a summary of just some data from a population. We included some of these patients. This is an Italian group, Marcello Denisio, who led this work. And so a retrospective study which looked at patients and their outcomes after anticoagulant-related GI bleeding. And I'd like to call your attention to the top row to look at clinically relevant bleeding. So this is major and clinically relevant non-major bleeds. Look at the high rates of bleeding here, 5%, 10% at 90 days. Really going forward in time, these patients are high risk of bleeding. Now, we didn't incorporate here, this is all patients, not just those who restarted or didn't restart. And you can see the rates of thromboembolism here as well, which go forward in time. Again, these are patients who have prothrombotic conditions at baseline. And so we would expect some degree of thromboembolism in that group. Lower than the rates of bleeding, though, I must add. And then here we're looking at death. High rates of death within 30 days, a bit lower than the ones that I told you about before. But if you look at 90 days, so here's a patient within 3 months, the risk of dying is 8% in this cohort. These are really important data. So again, we don't have causes of death. Many patients do not exsanguinate from their GI bleeds, but it is important to recognize that these patients are elderly and frail and highly comorbid. And so a bleeding event can ultimately lead to a series of events that cause their death. So very important to recognize that, and really does, I think, speak to the need for important prevention as part of that framework that I mentioned earlier. So Derek Little, who was a resident with me at the time, did a meta-analysis looking at anticoagulant restarting after GI bleeding. And we found similar results to the cohort study I just described to you before. For patients who resumed anticoagulants, compared to those who did not, the risk of GI bleeding was increased twofold, and the risk of thrombosis was lower. Again, we're seeing a mortality signal here, but it's likely that those patients who were restarted on anticoagulants had a better prognosis overall. And we're also seeing here that in these studies, anticoagulants were stopped for more than 3 months in 42% of patients. And so what do we know about the timing? So I just told you a little bit about starting versus restarting versus not. What about that? So if you're going to restart, what about the timing of restarting? We really have very limited data on this. This is one of the earlier studies from 2012, Dan Witt, which showed some results from patients who restarted warfarin versus none after GI bleeding. And you can see that patients who, on the left-hand side, we can see thrombosis, and on the right-hand side, you can see recurrent GI bleeding. On the left-hand side, you can see that patients who had restarted anticoagulants had a reduced risk of thrombosis. And on the right-hand side, we see a similar risk of bleeding, although I would say here that the effect of bleeding was not excluded in patients who restarted versus not, with a hazard ratio of 1.32, that, with really wide confidence intervals. So to me, this means I'm not sure that a clinically significant effect on bleeding was ruled out with these results, but regardless, that's what they showed. And this was, again, the rate of GI bleeding was higher in patients who resumed 1 to 7 days after the index GI bleed compared to other time points, so 12% versus 6%. Just keep that 7-day period in mind, because that's kind of a number that we've seen it, and we'll see in the next study as well. So this is a study, another study done in 2014, Qureshi. This is a cohort of patients who restarted warfarin or not after GI bleeding. And you can see in this chart that the patients who restarted warfarin had a reduced risk of thrombosis compared to those who did. And you can also see on the right-hand side now that the the risk of GI bleeding was similar among patients who restarted versus those who did not. Again, a hazard ratio of 1.18 here. But what you can also see is that the patients who restarted warfarin within 7 days had the highest risk of recurrent GI bleeding compared to other time points. So we're still looking around 7 days, and we're wondering maybe 7 days is like a time frame for us to work with in terms of restarting anticoagulants. Again, we see, similar to previous studies, there was a reduced risk of death seen in patients who restarted anticoagulation. But again, these are patients treated in clinical practice. And so we know that those patients likely had a better prognosis overall, or at least it's the highly likely that they did. In our cohort study, we found similar findings: an increased risk of bleeding, reduced risk of thrombosis, and then that mortality signal as well. So I wanted to just take a few minutes to talk a bit about just what I've been working on, and to try to chip away at some of these issues. It is a very challenging space for lots of reasons. There are a bunch of studies that we've done already, a meta-analysis and the cohort study. We did a study looking at physician values and preferences, which I'll tell you about. The goal here really is to conduct a definitive randomized controlled trial. And so some of these studies were sort of foundational studies to help build that and understand how we could do a trial and what type of trial to do. So we did survey physicians. We did a mixed method study where we looked at, we did focus groups of physicians that manage patients restarting anticoagulants after GI bleeding, and then conducted an international survey using discrete choice experiments, which really showed that the main factor that influenced physician decision-making about restarting anticoagulants after bleeding was rebleeding risk, but this was followed closely by thrombosis risk. And again, what do these mean? This is a survey methodology that really allows you to assign an importance score. Ultimately, you can derive utilities from this type of methodology, where it sort of where you rank factors that are important for respondents when making decisions about different types of things, including healthcare and other types of things. So we're seeing here bleeding risk is number one, but really closely followed by thrombosis risk. This isn't probably very surprising to people, but in any case, that's what we showed. We also asked the respondents to identify their preferences based on different scenarios. So what I wanted to focus on the right-hand side, you'll see this is the patients who were at low rebleeding risk, and you can see that there was very little equipoise for the respondents. People who had low rebleeding risk, the vast majority of people would resume anticoagulants within 7 days. We chose that 7 days from that previous literature. But if we look on the left-hand side, you can see these are the scenarios where a patient would be presented who has a high bleeding risk. On the top, we have high thrombosis risk, high rebleeding risk. The bottom is low thrombosis risk, high rebleeding risk. So you can see that for the patient who had a high thrombosis risk and a high rebleeding risk, the majority of respondents would resume anticoagulation within 7 or 14 days. That makes sense. You're trading off, you're saying, maybe the risk of rebleeding is worth it because the patient is at high risk of thrombosis. So you're more motivated to reduce the risk of thrombosis and take that chance of bleeding early on. Whereas if a person had a low thrombosis risk, you can see there's much more equipoise here. Among those responses, we see people wanting to resume within 14 days or 30 days, or maybe some wouldn't even resume at all. So this really led to the pilot study, which we're currently doing in Ottawa and soon to be starting in Calgary and hopefully Hamilton, where we're looking at patients who have had a major anticoagulant-related bleed and are admitted to hospital, and we're using a thrombotic risk stratified approach in order to restart their DOAC. High thrombotic risk patients would restart within 7 days, and moderate thrombotic risk patients would be restarted within 14 days. Sorry, that's an error. And really, the treating team can choose the exact timing and the dose and the drug. And we're really looking at whether or not we can recruit these patients. We're also going to use a registry arm to help identify, the reasons why patients were not enrolled in the main trial, and to just look at some management strategies. We're also doing a patient values and preferences study for anticoagulants after GI bleeding, similar to the one that I mentioned for the physicians. We've done some semi-structured interviews and focus groups, and then we're going to plan for a larger discrete choice experiment survey to really identify the factors that are important for patients when making decisions about anticoagulation after GI bleeding in collaboration with their family members. I wanted to briefly touch upon this, and I'm not sure if Ashkan's going to talk about it further, but there is an option for patients who are considered to have contraindications to anticoagulation. And again, we have some limited data in this space, particularly in patients who are at high risk of bleeding. But regardless, this is and who have atrial fibrillation. This is from the Canadian AF guidelines. And these guidelines suggest that percutaneous intervention, so this would be in someone who you feel should not restart anticoagulants. Maybe now we're considering left atrial appendage occlusion for those patients. And so there are weak recommendations here for considering a left atrial appendage occlusion for patients, with atrial fibrillation who have absolute contraindications. However, what an absolute contraindication is rather uncertain. But it is something that is perhaps underutilized, often because of just limited evidence. I'm just going to breeze through these next ones because I think it's a little bit beyond the scope of what we wanted to talk to today. But just to say that left atrial appendage is something that is an option, and I'd be interested in hearing if people have referred their patients for that. Because there's no one-size-fits-all approach, it is really important to just have some framework to help make decisions. It's important to make sure that the bleeding has stopped in your patient before restarting anticoagulants and that they have an ongoing indication. That's really important. And then you are weighing thrombosis and bleeding risk ultimately, which includes things like the absolute risk. So like the number, what's the chance or the number that a patient is going to have a problem. But not just that, it's not just the absolute number, but the type of thrombosis or the type of bleeding, because clearly ischemic stroke has a different outcome than deep vein thrombosis. So very important to understand both the absolute number and the type, including short and long-term complications. Same thing with bleeding. Is it a site of bleeding that's amenable to intervention? How severe was the bleed, and other sorts of things. This should be done really with patients and caregivers, but also in a multidisciplinary environment, so that you're really asking the experts, like Ashkan, for example. I don't know a lot about intracranial hemorrhage, but there are people who do, and so engaging those people in these decisions will really help you make the best decisions for your patients. And then finally, really this is part of a long-term management strategy where we don't just put people in anticoagulants and say, see you later, have a nice life. It really is about managing risk factors and optimizing therapy, to enhance safety. So we really need to be seeing these patients on, some sort of regular basis. Somebody needs to be seeing these patients, maybe not necessarily us all the time. Evaluate and address modifiable bleeding risk factors is really important. And I'll end there with my slide and hand the mic over to Ashkan. I hope I didn't take too much time away from him, because it would be really great to have some discussion at the end. So thanks so much, everybody, for your attention. Take it away.
Great, thanks so much, Deb. And good morning, everyone. I'll apologize in advance in case we get interrupted, just because, disclaimer, I'm off site at a surgical family waiting room because one of my family members is undergoing a surgery this morning. But I found a quiet space, and I'm hoping it'll stay quiet for the remainder of this session. It's a pleasure to be presenting to you today on this topic. It's something that I've been thinking about for some time since I joined McMaster in 2014. And something I've actually discussed with Deb quite a bit, and I think Deb is being gracious. I think in terms of one reaching out to the other for complicated cases, I'm probably reaching out more to Deb than she is to me. But in terms of so the topic really I'm going to tackle is what to do in patients who've had an intracranial hemorrhage, which of course is a much more grave type of anticoagulant related bleed that has worse outcomes. I do have several relevant disclosures in that I've worked in various capacities with companies that produce direct-acting oral anticoagulants, and currently have an investigator-initiated grant from Daiichi Sankyo for the ENRICH-AF trial, which is addressing this question that I'll speak to you briefly during this presentation. Objectives are going to be to discuss the dilemma of reinitiating anticoagulation in ICE survivors with a focus on atrial fibrillation. I think this is where the question probably has the most greatest equipoise. In patients with VTE, at least for briefly, we can always consider IVC filters. And with patients with mechanical valves, we don't really have a choice as to kind of whether to resume. It's more becomes a question of when, and we'll touch on that a bit. But most of the discussion will be centered on AF. We'll review some of the emerging evidence on this topic and then highlight ongoing trials. And I'll also mention my current practice in the absence of high-level evidence. One thing when we're talking about AF, of course, AF is one of the leading causes of ischemic stroke, and actually the leading cause of cardioembolic ischemic stroke. And the clots that form often in the left atrial appendage in patients with atrial fibrillation tend to be large ones that block proximal cerebral blood vessels that then lead to large territorial infarcts that have the highest rate of death and long-term disability amongst all ischemic stroke subtypes. Fortunately, we have effective medications at mitigating the risk of ischemic stroke in patients with AF, and that's anticoagulation, historically with vitamin K antagonists, and now with direct-acting oral anticoagulants. And as you heard from Deb, these are very effective, and as a whole, anticoagulation versus no anticoagulation results in about a 67% relative risk reduction in these large, devastating ischemic strokes. But anytime we're asking this question about whether or not to resume anticoagulation we need, irrespective of the indication, really, we need to weigh the known benefits of these drugs in reducing thromboembolic events or ischemic vascular events against their propensity to increase or potential propensity to increase the risk of recurrent hemorrhage, as well as their potential to cause more severe hemorrhages that are larger and result in greater death and disability than if someone were not to be on a blood thinner. Conversely, in the context of AFib, we also know that not only does anticoagulation reduce the rate of ischemic stroke, but also the severity of ischemic stroke, if someone were to have breakthrough infarcts on anticoagulation, tend to be smaller with less disability than if that ischemic stroke were to occur off anticoagulation. So these are really the competing risks and benefits that we're trying to weigh. And as patients with ICH were excluded from all randomized controlled trials that have investigated and established the benefit of anticoagulation in patients with atrial fibrillation, as you can imagine, current guidelines cannot provide any firm recommendations. The European Stroke Organization guidelines for ICH that are just being revised now, but our most recent iteration has been published, this was in 2014, basically don't even comment on it. They say in the absence of randomized trials, we cannot provide any recommendations. In the Canadian Stroke Practice recommendations, we provided some guidance based on kind of the available observational evidence, and really not really all that helpful, because we essentially say that it should be individualized according to the patient's risk of recurrent hemorrhage and thromboembolism. And we note that if anticoagulation were to be resumed, direct-acting oral anticoagulants would be favored based on their favorable ICH risk relative to warfarin, but acknowledge that this comes from trials where patients with ICH were excluded, and we're making indirect generalization here. And then the AHA 2022 guidelines essentially say in patients with non-valvular AF and spontaneous ICH, the resumption of anticoagulation to prevent thromboembolic events and reduce all-cause mortality may be considered based on a weighing benefit and risk. And this wording of preventing thromboembolic events and reducing all-cause mortality really is driven by observational data, which I'll show you in a sec. As you can imagine, there's significant equipoise and variability in clinical practice due to the uncertainty of current evidence. And we've conducted a survey of 228 specialists, mostly stroke neurologists, but also neurosurgeons and thrombosis experts. A third were members of ISTH. And we found that the rate of resumption, in terms of yes, no, the percentage of the top is patients who would never resume anticoagulation. The different colors is different timings, and I'll touch on that later in the talk. But really, the resumption rate varied according to the clinical case vignette that the physicians were provided. Where they felt most comfortable resuming anticoagulation was following head trauma on the basis that this was likely a single event provoked by the fall or trauma, and that their risk of recurrence was going to be low. And where they felt most unwilling or most concerned about resuming anticoagulation, where 2 out of 3 experts would not resume anticoagulation, was patients who had documented cerebral amyloid angiopathy, but still 1 out of 3 experts would have done so. And these were sophisticated enough respondents to distinguish cerebral amyloid angiopathy from lobar ICH, where actually 70% of respondents said they would resume anticoagulation for a lobar hemorrhage, but if that lobar hemorrhage was deemed to be due to CAAs, when they were more cautious. These results are similar to a debate that was conducted at an International Stroke Conference in 2018, where the question that was being debated was anticoagulation therapy should not be restarted in patients with anticoagulant-related lobar ICH, where 62% of the respondents disagreed, indicating they would resume anticoagulation after lobar ICH, whereas 30% agreed. So really that's almost that 70-30 split that we also showed. And the reason for this dichotomy between lobar and non-lobar ICH is due to the underlying prevalent form of hemorrhage-prone cerebral small vessel disease underlying these hemorrhages and their respective rates of recurrent ICH. So in patients who have non-lobar ICH, the most common age-related small vessel disease that contributes to this is arteriolosclerosis or hypertensive arteriopathy. And these patients have a recurrent risk of about 2 to 3% per year. And this could be mitigated with effective blood pressure control even further. Whereas in patients with lobar ICH, they're starting off at about a 5% per year rate of recurrent ICH. This could also be mitigated by blood pressure control. If they have CAA, and that is markers like microbleeds or a more potent marker of future hemorrhage called superficial siderosis that I'll show you in a second, it becomes 7% per year. And if they have disseminated cortical superficial siderosis, which is essentially hemosiderin staining along the surface of the brain and lining of sulci, and this is a marker of often occult convexity subarachnoid bleeds that occur on the surface of the brain and can often be asymptomatic. And they're noted on MRI. And this is basically just the chronic remnant iron staining of the brain, surface of the brain from these often occult bleeds. If they have 3 or more separate sulci involved on their MRI, and this is a special MRI sequence called an SWI, which is a blood sensitive sequence. Then if they have 3 or more sulci involved with this feature, then they're labeled as having disseminated cortical superficial siderosis. And if that's present, their risk of having a recurrent hemorrhage jumps to 13% per year. Whereas if they don't have this feature and they don't have 3 or more sulci involved with this imaging finding, then it actually goes back down to 5% per year. Now, we didn't have good observational data even until 2015, where a number of national registries began getting published, and initially from Germany and Denmark. And this is an aggregate meta-analysis that was published in 2017, pooling the data from these observational registries. And interestingly, their results for the prevention of ischemic stroke replicate kind of the randomized trial effect sizes. So basically, if you resume anticoagulation versus no anticoagulation, you're seeing a 66% risk reduction in ischemic stroke in these patients. However, what's surprising is that in these data sets, when you pool them, you're seeing no increased risk of recurrent ICH. And what's more alarming, or at least surprising rather, is that the majority of this data, over 95%, is coming with resuming anticoagulation with warfarin rather than the safer alternative of direct-acting oral anticoagulants. So one could take this data at face value and say, well, this is obviously a no-brainer. You're getting this massive ischemic stroke benefit and no increase in recurrent hemorrhage. So why are we just even discussing this as a lecture today? But the reality is that this data is observational and very likely confounded. And then the biggest confounder that could explain this is confounding by indication, in that physicians are choosing kind of lower risk patients who have more benign natural histories for recurrent hemorrhage to be anticoagulated. Those that have very high risk of future ICH are not being anticoagulated, and then you're getting this artifact of safety. And this is really why we need randomized trials to have a definitive answer to this question. Now, as you saw from our surveys, one of the most common way where physicians are selecting patients about whether or not they should resume anticoagulation is if they have lobar ICH due to CAA. And this is the only study I'm aware of that actually has dichotomized response to treatment according to non-lobar and lobar ICH, and then went further to look at those that had MRI markers of CAA as well. And in total, this is an individual participant data meta-analysis of 3 kind of prospective registries: the ERIC project, which is a multi-center registry in the US, Retrace, which is a multi-center registry prospective registry in Germany, and in the Massachusetts General Hospital ICH registry. And you're seeing, as Deb kind of alluded to, the resumption rate is not that high, actually, and it kind of goes against what our surveys would suggest, and that only a quarter to 30% of patients are actually being resumed in anticoagulation, and there's only a marginally increased risk, marginally increase in the rate of resuming anticoagulation those who had non-lobar ICH versus those that had lobar ICH, and the median time to resumption was 35 to 44 days. And when you compare resuming anticoagulation, again, the majority with warfarin, over 90% with warfarin versus no anticoagulation, you're seeing a massive 70% risk reduction in all-cause mortality for both lobar and deep ICH, a fourfold increase in favorable outcome defined as a modified Rankin scale of 0 to 3 at 1 year. 0 to 3 would mean that the patient can walk without the assistance of somebody else. So three being basically someone can walk without the assistance of somebody else, but may need some help with their activities of daily living. 0 being absolutely no symptoms from remaining. And then there was a benefit in ischemic stroke reduction as suspected, and again, no difference in recurrent ICH rate. And the hazard ratio for recurrent ICH was 1.17 and non-lobar ICH and 1.26 on lobar ICH. So not all that different. But as we discussed or alluded to earlier, not all lobar ICH are high risk, and actually not all of them are due to CAA. Only in the elderly with spontaneous lobar ICH, about 60 to 70% are due to CAA. Others are due to hypertensive arteriopathy, and this is assuming you've excluded macrovascular causes like vascular anomalies, etc. And some MRI findings that can suggest underlying CAA is patients who have only lobar microbleeds, strictly lobar microbleeds without microbleeds in deep areas, or if they had cortical superficial siderosis that we discussed earlier. And even in patients who had probable CAA, so these are people who have 2 or more hemorrhages, and the hemorrhages can be either siderosis, microbleeds, or a lobar symptomatic hemorrhagic stroke. There was a 70% reduction in all-cause mortality and a threefold increase in favorable outcome at 1 year. Now, again, you should take this with a grain of salt. And anytime you see very large mortality benefits in observational data, even if there's been propensity score matching and so forth, which are imperfect methods, you have to really question the integrity of the data, and particularly when the mortality benefit exceeds anything that has ever been seen in randomized trials. So for your reference, the benefit of anticoagulation versus no anticoagulation for mortality is about a 25% risk reduction, versus warfarin versus aspirin is about a 9% risk reduction in mortality that does not reach statistical significance in Bob Hart's kind of classic meta-analysis. Here you're seeing a 70% risk reduction in mortality benefit. And this really speaks to one, health. And any stroke was 11% in those who were avoiding anticoagulation. SOSTAR was the largest study conducted in the UK, and then Apache AF was another one that was published subsequent to SOSTAR in the Netherlands. And in total, 334 individuals have been randomized. Median follow-up crude mean is 1.5 years. And any stroke seems like there's about a 40% reduction, including ICH, with 12% in the anticoagulation arm versus 18.5% in the no anticoagulation arm. But the results were not consistent across the studies, in that although NASPAF and SOSTAR showed an overall reduction in any stroke with anticoagulation versus no anticoagulation, Apache AF did not. There was actually more stroke in the anticoagulation arm. So really just, although initial randomized data when aggregated does suggest net benefit, we do need to complete phase 3 trials to have a definitive answer. Another thing that was quite apparent, not only in the observational data that I mentioned earlier, but also that is emerging in these randomized trials, and this is data from SOSTAR, which is the largest study, the UK study, is that patients with ICH are not only at future risk of hemorrhage, but also at very high risk of ischemic events. And we don't actually understand exactly why, and there's many potential hypotheses that I won't get into, but just to prove the point, look at the rate of ischemic stroke in patients who were avoiding anticoagulation. It was 19% per year, and it was reduced to 3% per year with those who were being treated with anticoagulation. Having said that, this was offset in part by a doubling of intracranial hemorrhage with resuming anticoagulation versus not, and over 97% were resuming anticoagulation with direct-acting oral anticoagulants. And another thing to consider is that 7 of the 8 hemorrhages that occurred on anticoagulation were lethal, whereas none of the hemorrhages that occurred off anticoagulation were lethal. So really, the net benefit is still not clear, because not only can we no longer assume that patients, that the results of Averroes, where apixaban was as safe as aspirin for bleeding events, generalizes to patients after they've already had an ICH. So all the initial pilot randomized data suggests that's not the case. And that these patients are maybe, that anticoagulation may increase recurrent ICH by about twofold, even with direct-acting oral anticoagulants. And then there's also the numerical observation, although small numbers to date, that mortality on anticoagulation may be greater than mortality off anticoagulation. Now, the aggregate meta-analysis across these randomized trials suggests a 34 or 35% risk reduction in all stroke. And there was recently a Cochrane meta-analysis by our UK national leader for the ENRICH-AF trial, who's a senior author here, which looked at all 3 studies. And for the overall outcome of MACE, there was a statistically significant 39% risk reduction with resuming anticoagulation versus not. For all-cause mortality, there was no excess risk. For all major occlusive vascular events, a 70% risk reduction. For intracranial hemorrhage, although it's not statistically significant, the risk ratio is 2.43. And then for functional status with an MRS of 0 to 2 at 1 year, really no major difference. So again, the pooled pilot data suggests potential for benefit, but again, a net benefit, but this higher risk of intracranial hemorrhage lingers, and we really need the completion of large main phase 3 trials to definitively answer this question. And the largest being conducted globally right now is our trial that we're leading out of PHRI, which is the ENRICH-AF trial, where we've currently enrolled 600 participants and activated over 215 centers of our target of 250 in 20 countries. And hopefully we'll have our answer sometime in 2024, and that we can help guide treatment with level A evidence. We have about 20 centers coast to coast across Canada. So if you do have any participants or patients that you have equipoise about what to do and you want them to get enrolled in this study, shoot me an email and I'd be happy to put you in touch with your nearest local site principal investigator. So what am I doing myself in my practice at this time? Well, I am resuming anticoagulants in the majority of patients with ICH if they've only had one hemorrhage, and if they don't have lobar ICH with disseminated superficial siderosis. So anyone who has had only one bleed without disseminated siderosis, I will re-anticoagulate. However, the biggest thing is to ensure they have strict blood pressure control, and guideline recommended treatment of blood pressure after an ICH is targeting less than 130/80. And I ask all my patients to get home blood pressure monitors, keep blood pressure diaries, and to call me if more than 1 out of 5 sequential readings on separate days are above 130/80, at which point I rapidly titrate their blood pressure medications, and typically we'll get them within target within a month of their hemorrhage. And we've proven this in our pilot NASFAP ICH study with this method, that you can get these patients' blood pressure within target of less than 130/80. And anecdotally, this is, of course, anecdotes aren't worth much, and this is why we need to do randomized trials. But with aggressive blood pressure control and very close monitoring, we've had several cases now enrolled into ENRICH-AF. This is an open label trial randomizing patients to edoxaban standard dosing versus no anticoagulant therapy, which can include antiplatelet treatment. And we've had several patients with very aggressive MRIs for amyloid angiopathy now in the trial for over 2.5 years, who have not had recurrent bleeds after being assigned to a standard dosing edoxaban. Now, what about timing? Well, I'll go a bit more quickly here. Essentially, it's uncertain, very similar to what Deb was saying earlier. The literature-based estimates are anywhere between 3 days and 30 weeks. And based on this, the European Stroke Organization does not provide any recommendations. They say we need randomized trials. Canadian Stroke Risk Practice recommendations, we say that we don't know the optimal timing, and it really should be individualized to the patient. The AHA has selected a more conservative 7 to 8 week resumption time. Really, when I dissect the papers that kind of support these later time windows, there's other two issues. One is that they're either looking at patients with often subdural hemorrhages, which tend to rebleed at a high rate and rebleed early. And I think an 8 week time frame for a subdural hemorrhage makes really good sense. And then the other piece is that they're the ones that often censor early events, like they don't start counting events until after the very high risk early period where patients with ICH can have many thromboembolic events. So for ICH patients, I myself, so non-subdural intraparenchymal bleed patients, I myself really kind of target 2 to 4 weeks. And in our survey that I mentioned to you earlier, kind of the two most common time frames that were reported was 14 to 28 days, which is that 2 to 4 week time frame, or 4 to 12 weeks. In patients with mechanical valves who are at higher risk of thromboembolism, but also not as high as you would believe or we worry about, right? So the risk of having an ischemic stroke in someone who's got a mitral mechanical valve off anticoagulation is about 8 to kind of 12%, which puts them in the CHAD score of 4 to kind of 5, right? So it's not the end of the world if you had to wait 2 weeks or even a bit longer. In this particular survey of neurosurgeons and thrombosis experts, 4 to 14 days and at a median day of about 1 week was the timing where most people resumed anticoagulation after intracranial hemorrhage in patients with mechanical valves. Do I have time to go through this? I'll try to go through this quickly, and perhaps rather than going through it verbatim or in detail, I'll mention that this is a table you can refer to back in the slides when you're reviewing this at a later time. But essentially, I've broken down kind of my approach based on this risk of stroke and systemic embolism and risk of recurrent ICH in these patients. And if someone is at low risk for both, then I'll kind of use no anticoagulation, of course, if their CHADS is 0. DOAC after 2 to 4 weeks if they have AF with a CHAD that warrants anticoagulation, and then VKA after 2 to 4 weeks in those who have aortic mechanical valves, which are low risk. In patients that have high risk for ICH but low risk for thromboembolism, I'll consider no anticoagulation in those who have CHAD scores of 0 to 1. And by very high risk, I mean patients who've had recurrent lobar ICHs 2 or more, or disseminated superficial siderosis in addition to the lobar ICH. And I have a patient who has had 2 or more lobar ICH with an aortic mechanical valve without any additional high-risk features. So they don't have heart failure, they don't have AFib, they don't have a prothrombotic state, they've never had an ischemic stroke or thromboembolic event before. And that patient I've had following now for several years just on aspirin. So in these cases where they're at very high risk of recurrent hemorrhage and they have a low risk aortic mechanical valve, then you can get away with aspirin. And then for patients who are at high risk for thromboembolism but low risk for ICH, in AF, I resume anticoagulation after 2 weeks, and then VKA for mitral valves in 1 to 2 weeks. Again, anytime I resume anticoagulation, I want to make sure that I've repeated a CT scan to ensure that hematoma has stabilized and that their blood pressure is well controlled. And I'll mention some other mitigation strategies in a future slide. And then in patients who have high risk for both, then for AFib, I'll initiate DOACs after 4 weeks, unless they have disseminated siderosis or they've had 2 or more lobar ICH. And this is the only subgroup of patients where I currently consider for left atrial appendage occlusion. As Deb said, what defines an absolute contraindication to anticoagulation is really uncertain. In the CCS AF guidelines, they provide a little table where they suggest that a recurrent ICH is what would indicate it. So recurrent indicating 2 or more symptomatic hemorrhages. And here, if they've had 2 or more lobar ICH or 1 lobar ICH with disseminated siderosis, those are the patients I'll consider left atrial appendage closure. And in patients who've had multiple lobar hemorrhages, and really they have a mechanical valve that's high risk, and I really don't want to expose them to warfarin anymore. Very rarely in unique circumstances, I have actually asked the surgeon to revise their valve from a mechanical to a tissue valve. I won't have time to get through the mitigation strategies, but essentially, anytime you resume anticoagulation, this is a high-risk patient. You want to address all the risk factors for having another bleed if you're going to reinitiate anticoagulation, and blood pressure control is key. And to conclude, the dilemma of anticoagulation therapy post-ICH is certain to increase with their aging demographics. Confounding by indication limits interpretation of current observation data, and the results of pilot randomized trials have been conflicting. And I've shared with you my practice in the context of current evidence. And really, we need randomized trials to answer this question. So if you do have patients who are eligible for any of these studies, including DEBS or others you may have ongoing in your center, I do encourage you to randomize patients as often as possible so we could develop level A evidence to provide greater guidance for these patients. So thanks very much. I'm happy to go into Q&A, and if you had any other questions, here's my email and Twitter handle. Bye-bye. Thanks.
Well, thank you so much, both Ashkan and Deborah, for the wonderful presentation and very rich and informative guidance in a topic that is really critical, and the decision can clearly be very difficult. So I want to remind people, this is a chance for asking questions, and you have one of two ways. Either you put questions in the chat box, or you're welcome to raise your hand and go ahead and ask the question. Our two speakers would like to have it in an interactive way. So I have the first question now. Thank you for excellent presentation. Does your approach differ for SDH?
Good question. I have, with patients with SDH, I think ultimately I have less equipoise about whether to resume anticoagulation or not. In that, at least in my practice, I almost always will resume them, although I still have equipoise enough to put them in a trial because we just don't have good data. But the main key differentiating factor in patients with subdurals is that I wait longer. I wait about 8 weeks before I resume anticoagulation in these patients. And the times where I've tried to reinitiate them sooner and I repeat a CT scan, I'll often find a new pocket of kind of subacute blood within that subdural that kind of reinforces the need to wait longer. Now, the size of the hemorrhage also matters in subdurals, right? Really small subdurals, when you repeat imaging at 4 weeks, often they've resolved completely, and that's not an issue. It's really these more larger kind of hemispheric crescent-shaped subdurals that are the ones that often have early rebleeding.
Okay, thank you. Well, while people asking question, I guess the biggest thing from both presentation, whether GI or intracranial hemorrhage, and as we have heard, then the key message is the individualized approach, the importance of this after assessing the risk, the benefit and harm. But my question to both of you is, it can be difficult for some physicians to make that decision. How would you advise maybe the younger physicians who are seeing those patients who may be, worried about going one way or another?
Maybe I'll start, Ashkan. Thanks so much, Maha. That's like, I think this is, like the crux of the whole issue is that, while people think that someone should resume anticoagulation, often there's concerns about who is actually going to put the pen to paper or type it into the computer and actually make the prescription. Because of course, when we surveyed family physicians, for example, they were concerned that resuming anticoagulation in a patient and then causing future bleeding would harm the relationship with their patients. There's nobody wants to cause harm to a patient. So I think to me, what I tell the fellows and others, and even in my own life, I know we have other questions here that are coming, so I want to make sure we get to them. But I think it's really important to gather all the information that you can about, what happened, what was done to intervene, and whether or not that bleed is likely to recur, and if so, what could be done about it. And that means speaking to other people and also talking to patients and families. Some, people feel differently about this. Ultimately, it may be somebody needs to make a decision fundamentally, but I always think that, there is opportunity to gather evidence or data, and there is opportunity to defer decision-making for another time as well. So sometimes people or patients or families aren't ready to make a decision about resuming. And so this is something that can be revisited, but you need to make sure all your pieces are in place before you make that decision.
Thank you, Deb. And I can see Ashkan has already answered the question, so I can turn it to Ryan. Please go ahead and ask your
Perhaps
question.
maybe I'll just ask Deb's insights here as well, because it's been a while since I looked at the data. So last I checked, the risk of valve thrombosis off anticoagulation was about 1%. So although a very severe potential complication, not as frequent as we worry about. Is that percentage kind of ring true in your thoughts as well?
Yeah, you know what? I don't. I know it's low, lower possibly than we think, particularly with the newer valves that are. The thinking is that there's even a lower risk with some of the Onyx and newer valves that are coming along. And there's you think that this data is rife with like methodological issues, like the mechanical valve data is really tricky. I think what I always think is you cannot start anticoagulation for a theoretical risk of thrombosis when someone is actively having a life-threatening bleed. And so I always use that to guide my decision-making around this. A person is bleeding. We cannot restart their anticoagulation now for a future risk of thrombosis. And so it just is something that needs to be reassessed. But yes, I think it is probably lower than we think. Agree.
Okay, Ryan, would you like to go ahead?
Yeah, thank you. And thanks for the great presentation, both of you. Question, one thing I see in practice quite often is patients starting sort of a progressive, increasingly dose of anticoagulation after a bleed. And sometimes, if they're on a DOAC or warfarin, they'll just start with low molecular weight heparin if that's the case, and sort of do like half dose or prophylactic, then half, and then full. And same with DOACs, I'll also see, actually, and I've even seen this, patients with histories of intracranial hemorrhages who are just permanently on reduced dose DOACs, for instance, and they don't have those indications. So I just sort of wanted to get your thoughts on these practices, because it's something I see quite often.
Maybe I'll just tackle that quickly. I have mixed feelings about it. I think a slow escalating, like if you want to start with a lower dose and escalate from there with the patient tolerates it after a GI bleed, I think that's a reasonable approach and something we've done. When it comes to basically long-term off-label low dosing, it's kind of a two-edged sword. On the one hand, we have quite a bit of consistent data from the observational literature that this translates to higher risk of thromboembolic events, right? One of the biggest reasons people have breakthrough infarcts on anticoagulation right now in the context of AF is being underdosed based on the drug's label. So we want to avoid that where possible. The problem is patients with ACH were excluded from these trials. So we don't actually have a good dose for them. And at least in the context of edoxaban, we have a separate arm in the Engage EF-TME48 trial where they got the 30-15 milligram arm. So we have some randomized evidence for how a lower dose can fare. And then now there's the ElderCare data and frail kind of low BMI, low EGFR kind of elderly Japanese population where edoxaban 15 milligram dose was compared against placebo. I don't do it in my practice. Okay. I tend to go, the way I approach it is I want to maximize that 70% risk reduction in ischemic thromboembolic events to offset any increased risk of bleeding so that I maximize my net benefit. But if someone told me that these patients were excluded from trials, we don't know the appropriate dose for them, and we have this edoxaban data suggesting a lower dose can still do relatively well, I wouldn't be able to argue with that.
Okay. Antonius, I can see your hand. Go ahead, please.
Hello. Thank you very much for the excellent talk. My question is more about the observational studies that you showed in the beginning. That's my source of income, so to say. So I'm more interested in those. And so would you because you did the systematic review of observational studies, and about resuming anticoagulation after the bleed. And what would you say was the main problem? Was it immortal time bias that you explained very well, or was it confounding by indication? Because the first one is something that can be fixed. The second one is harder to fix in the observational setting. We don't randomize patients, but if it's immortal time, then I would say you could do the observational study and get results faster, and then also obviously do the RCT at the same time. So that would be my question about what do you think?
I'll take that, sure. So I think a little bit of both, Antonios. In those studies, these are primarily retrospective cohorts of patients. So all of it is problematic. Like, drug exposure is problematic, not time varying drug exposure is problematic. Immoral time bias certainly was an issue. Many of these studies don't account for competing risks, which is really, I think, problematic, particularly when lots of people die. So we did a cohort study using ICES, using data, linked databases through ICES. And we actually had a 3-month blanking period for that reason, because of, there are techniques to do. So we did do that. But again, you're missing that early post-discharge from hospital period when you're doing that. It's really hard unless you're doing a prospective study to capture, to define your follow-up and capture exposures. And to really define people. The other challenge is, of course, when you're doing a retrospective study, you're kind of falsely lumping people into one category of, resumed versus not resumed, when in fact that's like a future event. You know what I mean? So we treated that as a baseline characteristic, but in fact they were not, because the drug exposure status could change over time. So just there are a lot of interesting methodological issues with the data, which means that we really need either a really good quality prospective study. Well, I was trying to do some in order to make some headway for the GI bleeding space. I mean, I had planned to do a trial, and it just became increasingly clear that we just didn't have data to be able to even estimate event rates for that trial. So really just doing a prospective study is very beneficial for that reason. Yeah. Is that what you meant, sort of? I mean, I'm happy to chat about with you otherwise if you have expertise and interest anytime.
Thank you. That was my question, and maybe I could email you because it's a very interesting setting to do an observational study.
No, please do. That would be great. Please do. Yeah.
Okay. Any other questions? I don't see any more hands and nothing in the chat box. Christine, you had a question in the beginning. We're asking to verify that we answered your question, or you want to have a follow-up? Okay, there is.
I just put it. I think there's a meta-analysis I just found here. I'll put it in here for you about that issue of valve thrombosis.
Thank you, Deborah.
Low rate. Yeah, there he goes.
Okay. Well, I can see we are 12:07 now, and we're probably close to the end. And I'm sure our two speakers would be available to answer questions through email, so please reach out to them. And for now, I would like to once again thank our two speakers for the wonderful presentation and informative seminar. And I wish on behalf of the Planning Committee and CanVector to Ashkan a speedy recovery and safety for his family member. And now I think we can close the seminar. I wish you all the best and thank you so much.
Thank you.
Thanks, everyone.
Bye, Ashkan. Nice to see you.
Likewise. Now.